Hi, I'm Dr. Linda Chu. I'm an Associate Professor of Radiology at Johns Hopkins University, and today we will talk about multi-detector CT evaluation of acute pancreatitis. We'll review the classification systems for diagnosis of acute pancreatitis, go over some CT imaging features of acute pancreatitis and associated complications, briefly go over the clinical management of acute pancreatitis, and describe some emerging technologies in acute pancreatitis. So acute pancreatitis is caused by acute inflammation of the pancreas and adjacent tissue. It's a very common cause of abdominal pain and frequently leads to ER visits and hospital admissions. So it's a very expensive kind of clinical problem that we constantly deal with. The clinical presentation can be quite variable, from mild abdominal pain to multisystem organ failure. Some of the more common etiologies that we encounter include alcohol and gallstones, and the less common etiologies that we sometimes see include drug reaction, hypertriglyceridemia, underlying neoplasm. It could also be iatrogenic due to a ERCP or idiopathic. Acute pancreatitis can be divided into an early phase or late phase. The early phase refers to symptoms within the first week, and it's due to systemic disturbances from host responses to local pancreatic injury. It's basically a systemic inflammation. And the severity of pancreatitis is classified based on the presence or absence of organ failure. In patients who have either moderately severe or severe acute pancreatitis, they will go on to develop a late phase of acute pancreatitis that may last from weeks to months. And this is due to persistence of systemic signs of inflammation or presence of local complications, and as I said before, only occurs in patients with moderately severe or severe acute pancreatitis, because patients with mild acute pancreatitis, their symptoms would be expected to resolve within the first week or so. So in grading the severity of acute pancreatitis, we can divide them into mild, moderately severe, or severe acute pancreatitis based on the absence or presence of organ failure or systemic or local complications. In mild acute pancreatitis, the patients should not develop any organ failure. There should be no local or systemic complications. In patients with moderately severe acute pancreatitis, they may experience transient organ failure that will resolve within 48 hours, and they may develop local or systemic complications without persistent organ failure. In patients with severe acute pancreatitis, they develop persistent organ failure lasting more than 48 hours, and there is a very high associated mortality of up to 50%. Previously, people used a lot of different terminology for description of acute pancreatitis, and in 2012, with the revised Atlanta classification, they standardized how we use terms to describe acute pancreatitis. It requires two of the following three features: abdominal pain consistent with acute pancreatitis, serum lipase more than 3 times upper limit of normal, or characteristic findings of acute pancreatitis. When you look at these features, you only need 2 out of 3 to fulfill a clinical diagnosis of acute pancreatitis. So imaging is not strictly required for the diagnosis of acute pancreatitis, but it can provide essential information in assessing disease severity and associated complications. And last year, in late 2019, a whole host of papers came out, both from the ACR and in abdominal radiology, about the topic of acute pancreatitis. ACR published the Appropriateness Criteria for acute pancreatitis, and they listed 6 different scenarios, and as usual, they listed different imaging modalities and whether or not they are appropriate or not appropriate for evaluation. And in the next few slides, I will show you the ratings for CT. So generally, CT abdomen pelvis with intravenous contrast is rated very highly in the ACR Appropriateness Criteria. In most scenarios, it is rated as usually appropriate. The only scenario that they downgraded a bit to just maybe appropriate is the scenario with epigastric pain and increased amylase and lipase less than 48 to 72 hours after symptom onset. And this is because in this clinical scenario, the patients are presenting with pretty classic presentation of acute pancreatitis, and you don't really need imaging for the diagnosis. And this early on, you may also underestimate the degree of, say, pancreatic necrosis or associated complications. That's why it's rated less highly in this kind of classic scenario. For CT abdomen pelvis without contrast, the rating is not quite as good compared to CT with contrast. As we all know, IV contrast is very helpful for differentiating interstitial edematous pancreatitis from necrotizing pancreatitis, also very helpful in detection of fluid collections and vascular complications, so that's why CT without contrast is rated less highly. And CT abdomen pelvis with and without contrast is rated even less highly compared to without, mostly due to radiation concerns. And as I mentioned, in abdominal radiology, there were also a whole bunch of articles on the topic of acute pancreatitis. And they also describe in what clinical scenario should you image and when you should not image. So in that article, they said that if it's the first presentation of acute pancreatitis and the cause is uncertain, ultrasound is recommended to look for any gallbladder pathology, gallstones that may be the culprit for acute pancreatitis. CT with contrast is recommended in the acute setting. In patients with equivocal clinical presentation, they may have some vague abdominal pain, the labs may not be all that elevated, so in that setting it's recommended to differentiate pancreatitis from other causes of abdominal pain. And obviously, if there is deterioration of patient's condition, CT is recommended to look for any superimposed complications. So if patients have persistent symptoms after 7 or 21 days after onset, CT is recommended to assess disease severity and to guide clinical management. And if patients have clinical suspicion for biliary pancreatitis, ERCP is recommended within the first 24 hours so that it can be both used for diagnosis and to also relieve the biliary obstruction. In that article, they also talked about when not to image. So similar to the ACR Appropriateness Criteria, if patients come in with classic presentation with typical clinical symptoms, unequivocal elevation of amylase and lipase, CT is generally not recommended in the acute setting. And again, this is because scanning the patients this early may underestimate the severity of disease. Routine CT for initial assessment should not be performed, and the vast majority of complications can be suspected by clinical and biochemical assessment. And just to show you a few classic examples of pancreatitis, so here is a case of Gallstone pancreatitis. You can see the typical edematous appearance of the pancreas with some peripancreatic soft tissue stranding. If you look really hard in the common bile duct, it looks a little bit dilated, and there may be some subtle filling defect within the distal common bile duct. And if you window it, then you can really bring out the filling defects. And this was confirmed on MRCP, that you can see multiple filling defects within the distal common bile duct. This is a case of ERCP-induced pancreatitis, in which you can again see the peripancreatic soft tissue stranding, free fluid all around, and then you also see contrast from ERCP within the gallbladder and also free air within the abdomen. And coming back to the revised Atlanta classification for acute pancreatitis, basically they differentiate pancreatitis into interstitial edematous pancreatitis and necrotizing pancreatitis based on the absence or presence of tissue necrosis. And within interstitial edematous pancreatitis, in patients who have fluid collections, if those collections are within the first 4 weeks of symptom onset, they are called acute peripancreatic fluid collection, and if they persist beyond 4 weeks, they are pancreatic pseudocysts. And in patients who have necrotizing pancreatitis, and if they have fluid collections within 4 weeks of symptom onset, they are considered acute necrotic collection, whereas fluid collections that persist beyond 4 weeks are called walled-off necrosis. So first, let's talk about interstitial edematous pancreatitis. So this refers to acute inflammation of pancreatic parenchyma and peripancreatic tissue, and there is no tissue necrosis associated with it. So on imaging, we expect to see diffuse or focal enlargement of the pancreas, relatively homogeneous contrast enhancement, and we'll see some peripancreatic soft tissue stranding and or fluid. So this is a very classic example of interstitial edematous pancreatitis, in which you have this very edematous appearance of the pancreas and all that peripancreatic soft tissue stranding and free fluid. And notice that the whole pancreas enhances very homogeneously throughout. And this is another example. Similar to the previous example, we see the diffuse edematous enlargement of the pancreas with peripancreatic soft tissue stranding and fluid, homogeneous enhancement throughout. And this person underwent a follow-up CT 2 days later, and you can see that there's more fluid all around. There's more third spacing of fluid, more free fluid within the abdomen as well. But then the pancreas is still enhancing very homogeneously. And sometimes these cases of pancreatitis may be a little bit more subtle, as in this case, all you see is a little bit of peripancreatic soft tissue stranding and not much else. No, not much fluid or fluid collections around the pancreas. And as I mentioned before, when we encounter peripancreatic fluid associated with interstitial edematous pancreatitis, then these are referred to as acute peripancreatic fluid collections if they occur within the first 4 weeks of symptom onset. We expect to see homogeneous fluid collection with fluid density. Because it's so early on, we don't expect to see a definable wall. And we should not expect to see any intrapancreatic extension, because the presence of intrapancreatic extension would signal that there's tissue necrosis, and that would be classified as necrotizing pancreatitis. So here are some examples of acute peripancreatic fluid collection. This is a patient coming in with pancreatitis. At the baseline exam, you see very ill-defined peripancreatic fluid, and as time goes on, at the 2-week mark and the 4-week mark, the fluid collection become more and more defined. But still, when you look at the internal component, it still looks very simple. There's no soft tissue component. It looks like simple fluid. And when these fluid collections persist beyond 4 weeks, they would gradually develop and become more loculated and encapsulated with well-defined wall. Then they are referred to as pancreatic pseudocysts. So these are well-circumscribed fluid collections with defined wall, but again, we should expect to see homogeneous fluid density without any non-liquid or solid component. This is an example of a patient who had pancreatitis 3 years ago and who still has this persistent fluid collection adjacent to the tail of pancreas with a pancreatic pseudocyst. This is a similar example of a patient who had multiple episodes of acute pancreatitis, and again, you have this persistent peripancreatic fluid collection that's not going away, and that is a pancreatic pseudocyst. In 5 to 10% of cases of acute pancreatitis, patients will develop tissue necrosis within the pancreas, and that is referred to as necrotizing pancreatitis. The necrosis can involve either the pancreatic parenchyma, the peripancreatic soft tissue, or both. The most common type involves both the pancreatic and the peripancreatic tissues. Necrotizing pancreatitis, with all that inflammation, it impairs the pancreatic perfusion, and these signs of pancreatic and peripancreatic necrosis can evolve over several days. And that's the reason that the early CT may underestimate the eventual extent of necrosis. We identify necrotizing pancreatitis based on non-enhancement of the pancreatic parenchyma and or non-enhancing heterogeneous peripancreatic collection. This is a classic case of necrotizing pancreatitis in which you can see, again, very edematous appearance of the pancreas, but as opposed to the interstitial edematous pancreatitis cases that I have shown previously, in this example, you see that the pancreatic head and the proximal body is poorly enhancing relative to the pancreatic tail. And again, you see the ill-defined peripancreatic soft tissue stranding and fluid. And on this lower slide, again, you see similar findings that the portions of the pancreas are just not enhancing. This patient underwent follow-up MRI 3 days later. Again, we see similar findings. We have abnormal T2 signal within the portion of the involved pancreas. On the venous phase images, we see very poor enhancement, which we can confirm on subtraction images that that area of the pancreas is truly not enhancing. How about this example? So it's a non-contrast CT, patient coming in with abdominal pain and elevated lipase. Do you think it's a case of interstitial edematous pancreatitis, or is it necrotizing pancreatitis? So the answer is that it's a case of necrotizing pancreatitis, and honestly, it is very difficult to tell on non-contrast exam, and that is why we really need contrast to distinguish between interstitial edematous pancreatitis and necrotizing pancreatitis. So in this example here, again, you see that the pancreatic head and the proximal body is enhancing normally, but portions of the pancreatic tail is just not enhancing, and you have very heterogeneous collection within the peripancreatic soft tissues. How about this example? Do you think it is interstitial edematous pancreatitis or necrotizing pancreatitis? This time I actually gave you contrast, but patient is coming in on the first day. Alright, so the answer is this is also a case of necrotizing pancreatitis. So at the baseline exam, people may argue, is this pancreas enhancing normally or not? I think it's fairly normal enhancement that I can't complain too much about it. But then when you look at follow-up exam on the 3 days and 5 days later, clearly this portion of the pancreatic body and neck are just not enhancing normally. And this is a case of necrotizing pancreatitis. Again, going back to the earlier point of if you scan the patients too early when they first come in with symptoms, those alterations of pancreatic perfusion may not have gone on for long enough to result in tissue necrosis, so we may underestimate the eventual extent of tissue necrosis. And this is another example with a classic necrotizing pancreatitis, and as the necrotizing pancreatitis goes on, then again you start to develop more of these collections that if you just look at the baseline exam, you may underestimate the eventual extent of tissue necrosis. And just to show you an example of peripancreatic necrosis, in this example, the pancreas enhances fairly normally, whereas the tissue necrosis is more within the peripancreatic soft tissues. And just to show you some examples of acute necrotic collection, so these are collections with variable amounts of both fluid and necrosis associated with necrotizing pancreatitis, and they occur within the first 4 weeks of onset. And on CT, we see them as heterogeneous collection with varying amounts of solid necrotic material and fluid. And because it's so early on, we do not expect to see a definable wall, and it can be very difficult to differentiate between an acute peripancreatic fluid collection and an acute necrotic collection within the first week. So this is an example of an acute necrotic collection. You can see this large peripancreatic fluid collection that has a lot of both fluid components and also soft tissue components, so that you can tell that this is a more complex acute necrotic collection. And this is an an example, again, you can see that it's a heterogeneous collection with both fluid and a little bit denser soft tissue components. And as time goes on, you will gradually see more and more definition around the wall, better encapsulation, and after 4 weeks, these acute necrotic collections become walled-off necrosis. And sometimes on CT, it can be a little bit difficult to appreciate the soft tissue components, such as this example here. When you put the ROI on it, the Hounsfield units averages around 23 Hounsfield units, so it doesn't look very impressive. But when you look at the MRI, you can clearly see that there's very heterogeneous components within the collection. So after 4 weeks, these collections become walled-off necrosis, and you would see heterogeneous collection with liquid and non-liquid density with varying degrees of loculation. The difference is that after the 4-week mark, we tend to see a well-defined wall around the fluid collection. So these are examples of some walled-off necrosis. So you see a very nicely defined wall around the margins of this collection. And you also see kind of soft tissue components around the periphery. And this is where history becomes very important, because if the patient did not come in with history of pancreatitis, with this appearance, you may also consider a differential of pancreatic cystic neoplasms. Another example of walled-off necrosis, here you see a lot of peripancreatic soft tissue necrosis within it, and you see components with fat and different densities within this walled-off necrosis. So here we conclude part 1 of our talk on acute pancreatitis, and then we'll see you back for part 2 in a little bit.
If you liked what you heard here today, please make sure to hit that subscribe button and visit our website CTisus.com for lectures, quizzes, pearls, and more. Also,